Today we'll see IUGR. The outline is definition, causes, symmetric and asymmetric IUGR, management of IUGR, time of delivery, and ponderal index. Now moving to the definition, it is the estimated fetal weight that is less than 10th percentile or abdominal circumference on ultrasound that is less than 10 percentile. So if it is around 10 percentile, we call it as mild IUGR. If it is between 3 to 10 percentile, we call it as moderate IUGR. If it is less than 3 percentile, we call it as severe IUGR. IUGR can be a result of fetal, maternal, and placental problems. What are the causes? Fetal causes. So, fetal intrauterine infection, congenital anomalies, chromosomal or genetic anomalies, and multifetal pregnancy. What congenital anomaly causes IUGR? Omphalocele, gastroschisis, skeletal dysplasia, diaphragmatic hernia. The chromosomal anomaly causing IUGR are triploidy trisomy 18. In trisomy 18, IUGR is present along with polyhydramnios. Usually, IUGR is associated with oligohydramnios. What are the maternal causes? Medical and obstetric causes. Teratogenic exposure to the mother, low BMI or poor weight gain in pregnancy, mothers living in high altitude, short inter-pregnancy interval, increased maternal age. What are the placental causes? Uteroplacental insufficiency, antiphospholipid antibody syndrome, placenta or cord anomalies, single umbilical artery, filamentous cord insertion, and circumvallate placenta. Not fetal causes leads to symmetrical IUGR, which is early in onset, that is less than 32 weeks, whereas placental and maternal causes leads to asymmetrical IUGR, which is late in onset, that is greater than 32 weeks. Coming to symmetrical IUGR, it represents a small proportion, that is 20 to 30% of fetal growth restriction cases. These infants have reduction in all organ systems, along with head, body, length, all are proportionally affected. Symmetrical fetal growth restriction begins early in gestation and usually caused by intrinsic fetal factors such as congenital infection or chromosomal or congenital anomalies. What happens is decreased nutrient supply affects all organs symmetrically. What are the investigations? You have to do level 2 scan, genetic studies, and test for fetal infections. Coming to asymmetrical IUGR, which is late in onset, 72, that is a major proportion. 70 to 80% of FGR cases have disproportionate growth restriction. Head circumference is preserved. This is an important point. Length is somewhat affected, whereas weight is compromised to a greater extent. So the normal sized head appears relatively large compared to the size of the trunk and the extremity. Abnormal growth typically begins in late second trimester or third trimester, resulting from reduction in fetal nutrients that limit the glycogen and fat storage, but it allows continued brain growth. So it is a brain sparing effect. Indications of karyotyping in IUGR. We'll do karyotyping in very early onset severe IUGR, that is less than 24 weeks. If polyhydramnios is present, if fetal malformation is present, in ultrasound, soft tissue markers of aneuploid is present. What is constitutionally small baby? In IUGR, weight is less than 10 percentile, as I said. It is associated with oligohydramnios and abnormal Doppler studies. But in constitutionally small babies, the weight is between 5 to 10 percentile. There is no oligohydramnios and no Doppler abnormality associated with. Abdominal circumference may be greater than 10 percentile and mothers may also be small. This is a differential point. Screening for IUGR. You have to measure the symphysis fundal height. It will be corresponding to weeks of gestation in centimeters. If the symphysis fundal height in centimeter is less than 3 centimeters of the gestational age, there is discrepancy in the growth. So you have to do a ultrasound to estimate estimated fetal weight and amniotic fluid volume. Growth scan can be performed twice at 32 weeks and 36 weeks. If on ultrasound the estimated fetal weight is less than 10 percentile or abdominal circumference is less than 10 percentile, you can diagnose it is IUGR. Now you have to check for biometric ratios. That is HC-AC ratio. In normal pregnancy, the HC-AC ratio decreases with increasing gestation. But in case of asymmetric IUGR, the numerator remains constant and the denominator decreases. So there will be increase in this ratio. The decrease in AC will be more than HC, as I said. So if HC-AC ratio is greater than 2 standard deviation, it indicates asymmetric IUGR. In case of FL will be almost remaining constant and the AC will be decreasing. FL is femur length. AC will be decreasing. So this ratio will also increase. If you have to rule out as HC-AC ratio also increases in macrocephaly and increased intracranial pressure. In early onset IUGR, that is less than 24 weeks, you have to do level 2 scan, karyotyping, and torch test. In late onset IUGR, you have to do Doppler studies to detect uteroplacental insufficiency. Most important and first vessel to show changes of uteroplacental insufficiency is umbilical artery Doppler. Normally, ST ratio of umbilical artery is less than 3. If ST ratio is greater than or equal to 3, then it is uteroplacental insufficiency. This happens when there is greater than 30% of the villi cease to function. In uteroplacental insufficiency, the decreased blood flow to the fetus, so there is redistribution of blood to brain, so there is brain sparing effect. In early uteroplacental insufficiency, the middle cerebral artery is normal, it is not affected. As the uteroplacental insufficiency progresses, the resistance in MCA decreases. In late UPI, the SD ratio decreases in this case. In MCA, SD ratio decreases and end diastolic velocity increases. The last result to show reversal of end diastolic flow is ductus venosus. It indicates impending death. What is management of IUGR? You have to do ultrasound for fetal growth every 3 weeks and weekly evaluation of amniotic fluid and weekly evaluation of umbilical artery Doppler. You have to suspect fetal growth restriction. Then you have to do a detailed USG umbilical artery Doppler and offer genetic studies for early onset FGR, anatomical abnormality, and polyhydramnios. Maternal serum or amniotic fluid testing for torch infection. You have to do serial fetal growth assessment every 3 weekly and umbilical artery Doppler, amniotic fluid assessment weekly, fetal surveillance, NST or biophysical score should be done. So this will be divided into 3 categories. The first category is normal umbilical artery Doppler. The second category is umbilical artery Doppler with absent end diastolic flow. And in third case, the umbilical artery Doppler with reversed end diastolic flow. First, we'll see normal umbilical artery Doppler. We'll be doing, in case of normal umbilical artery Doppler, we'll be doing umbilical artery Doppler, non-stress test, biophysical score, and fetal growth restrictions weekly. If the estimated fetal weight or expected fetal weight is 3 to 9 percentile, you will deliver the baby at 38 to 39 weeks. If the estimated fetal weight is less than 3 percentile, you will deliver at 37 weeks. If it is present along with oligohydramnios, you will be delivering at 36 to 37 weeks. So with normal fetal heart rate patterns, you can try a vaginal delivery, but during delivery, some of the fetuses don't tolerate, especially if oligohydramnios is present. In such cases, do C-section. So moving on to the second scenario, umbilical artery Doppler with absent end diastolic flow, you have to consider hospitalization, corticosteroids for lung maturity, NST 1 to 2 times a day if hospitalized, 1 to 2 times a week if in outpatient basis. Umbilical artery Doppler is done 2 to 3 times a week. Fetal growth assessment every 3 weeks. You have to deliver at 33 to 34 weeks. Coming to the third category, umbilical artery Doppler with reversed end-diastolic flow. You have to surely you have to hospitalize the patient, and corticosteroids is given. As she is hospitalized, you have to do NST 1 to 2 times a day. You have to do umbilical artery Doppler 2 to 3 times a week. It is same as the second category. Deliver at 30 to 32 weeks. Note there is no role of nutrient supplement, aspirin, heparin, oxygen therapy, and anti-hypertensives. So, what are the neonatal outcomes of IUGR? So, neonatal hypoxia, meconium aspiration syndrome, hypoglycemia, polycythemia, and hyperviscosity. What the IUGR can affect adults' life, that is Parker's hypothesis. In adult, mortality and morbidity is proportional to the cardiac dysfunction that can be related to fetal growth restriction. Fetal growth restriction affects organ development. This can lead to hypertension, atherosclerosis, and type 2 diabetes mellitus in adult life. Infection leading to IUGR, rubella, cytomegalovirus, tuberculosis, syphilis, toxoplasma gondii, and congenital malaria. What is ponderal index? Weight parameters at birth are not sensitive measures to detect IUGR. So useful particularly in PI is useful particularly in asymmetric IUGR. PI is the ratio of body weight to length. So you have to do weight in grams into 100 divided by length in centimeters, the cube of it. With normal growth, PI is increased gradually from 30 to 37 weeks, then remains constant. If PI is less than the 10th percentile, it denotes fetal malnutrition is present. If PI is less than third percentile, it denotes severe wasting. Thank you.